Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello everybody. My topic in this lecture will be evaluation of fetal head and neck anatomy and pathologies with fetal MRI. Fetal MRI is useful in evaluating normal facial structures and in defining the extent of head and neck masses. Abnormalities of fetal head and neck are an extensive group of diseases that include malformations and masses. Facial structural evaluation includes the orbits, the lips and palate, the profile, and the ears. Single-shot T2 weighted sequences are the workhorse of fetal MRI. In my institution, we acquire both Hess and Truefield sequences. Both of these sequences are very helpful for proper interpretation of fetal anatomy and understanding the pathologies. Susceptibility weighted sequences are very helpful, and despite its limited utility, T1 weighted images are problem solving in certain specific scenarios together with cine images. MRI is also known to show facial and cervical anatomy of the fetus in high anatomical detail. A true midline sagittal MR image and parasagittal MR images are important for assessing the facial profile. Forehead and chin must be on the same plane. These sequences show the frontal region that can be prominent or shortened. Nasal bone should be present. The nose and its curvature must be very clear. Nose should project beyond the plane of forehead and the chin. Top of ear should be at the level of the orbit. The upper and lower lips, the primary palate, the secondary palate should be visible. The primary palate includes the anterior portion of the alveolar ridge with 4 incisor teeth. The secondary palate consists of the remaining hard palate and the soft palate. Cine image is very important in evaluating the swallowing function and visualizing the normal anatomy. Here you can see upper and lower lip, tongue, chin, nose, primary and secondary palate very well. The oropharynx and the nasopharynx are also assessed on the sagittal anatomic plane of the cervical region and are filled with T2 hyperintense fluid that is well visualized during swallowing. The trachea and esophagus can also be identified when filled with swallowed amniotic fluid. The alveolar arc with tooth buds and the hard palate are well identified in axial plane at the maxillary level. The nasal cavity is depicted as small, slit-like T2 hyperintense areas containing amniotic fluid on both sides of the nasal septum. The spacing of the eyes, the eyeball morphology, the emergence of the optic nerve, the vitreous signal, and the presence of the lens can be also appreciated on axial images. Coronal images are useful for eye measurements and evaluating the integrity of fetal lips and the palate and provide assessment of the nose and the ears. This view is also quite useful for the diagnosis of cleft lip and cleft palate. Abnormalities of the fetal head and neck are an extensive group of diseases that can include malformation and masses. These are some of the lesions that we will cover in this lecture. Calvarial size, shape, and mineralization changes are all considered as abnormalities of the fetal skull. Macrocephaly is often related to underlying abnormality such as hydrocephalus and intracranial tumor. Microcephaly can be seen with various syndromes and malformations. A triangular, strawberry-shaped configuration to the head is associated with trisomy 18. Triangular morphology of the calvarium is also classical findings in KIR2 malformation. Spalding signs refers to overlapping of calvarial bones as the brain collapses following in utero fetal death. Craniosynostosis can occasionally be suspected with an abnormal skull shape. A prominent frontal region with bossing can be found in fetuses with achondroplasia and some of other dwarfism. In the prenatal period, there are many types of scalp masses. Hemangioma, lymphatic malformation, and dermoid and epidermoid cyst are some of these lesions. Meningoencephalocele and encephalocele are also considered in scalp lesion with calvarial defects. An algorithmic approach may be useful. This is based on initially identification of the presence or absence of the vascularity in the scalp lesion. The next step is to look for an underlying calvarial defect suggesting intracranial communication. Perinatologists referred a case of fetal cystic scalp lesion with a list of these differentials. Extracranial fetal masses are findings of major diagnostic alarm, of which encephalocele is the primary consideration. With Doppler ultrasound, no tissue or vascularity were found in this lesion. No abnormal or communicating blood vessels were seen under the lesion on power Doppler. If you look at our flowchart, diagnostic algorithm is directed towards cystic scalp masses of ectodermal origin. If you look at the MRI, this lesion has no intracranial communication. If it is misinterpreted as an encephalocele, it may result in unnecessary termination of the pregnancy. Therefore, when you detect a lesion in the fetal scalp in the region of anterior fontanelle without an intracranial communication, think of dermoid cyst as a major differential. Presence of intracranial communication in an avascular cystic scalp lesion points towards neuroectodermal lesions like meningocele or encephalocele. Evaluation of abnormalities of the venous sinus anatomy is very critical for the diagnosis of atretic cephalocele when you detect a midline cystic scalp lesion. This patient was referred to me with a fetal scalp masses in one of the T1s. This mass had a broad base on the scalp. No skull defects or abnormal intracranial lesions were noted. Considering the mixed signal intensity and internal signal void in the MRI and prominent flow signals in the Doppler ultrasonography, prenatal diagnosis considered as fetal scalp hemangioma. It's important to suspect and diagnose hemangioma as early as possible because such an early diagnosis can help decide the delivery mode and timing of the delivery. These are the images 3 months after birth. If you compare with the prenatal images, there is a considerable amount of decrease in the size of the lesion. Congenital hemangiomas grow in utero in contradistinction to infantile hemangiomas, which typically appear postnatally. Considering the size regression and involution without any treatment, this mass is considered as rapidly involuting congenital hemangioma. Let's have a look at this case. On coronal images, there is a significant accumulation of lymphatic fluid within the subcutaneous spaces. Because of the huge size, there is a mass effect on the neck that causes posterior abnormality. But this mass doesn't exert a prominent mass effect on trachea or areoepiglottic folds. Lymphatic malformations are typically located within the posterior subcutaneous tissue, although they frequently wrap around laterally and may involve only one side of the neck, causing postural abnormalities. This is another patient with very similar findings to previous one. In this patient, there is a prominent hyperextension of the neck due to the huge cervical mass. The human face is a complex anatomic structure with an equally complex embryologic development. Derangement of the development process can result in various structural anomalies, which range from a mainly cosmetic deformity to a potentially life-threatening conditions. These anomalies can occur as isolated or can be associated with some anomalies or can be a part of various syndromes, thus serving as diagnostic clues in such cases. Proper evaluation of fetal facial deformities can help in prognostication, family counseling, and perinatal or early postnatal interventions. Let's start with orbits. A routine assessment of fetal eye during cerebral and head and neck examination should be done because the brain and the eye show a common embryological origin. Measurements include the interocular distance, the binocular distance, and the ocular distance itself. Hypotelorism refers to the eyes being abnormally close together. Hypertelorism should be recognized when the interorbital diameter is larger than a single orbit width. An easy approach to recognizing hypotelorism is that a normal interorbital diameter should roughly equal a single orbit width. Hypotelorism is rarely seen in isolation. As with hypotelorism, isolated primary hypertelorism is also very rare. Anophthalmia may occur when the optic vesicle fails to form appropriately. It will be either due to primary anophthalmia, which is usually associated with genetic and chromosomal syndromes, or secondary anophthalmia resulting to the destructive events. Microphthalmia is a globe that measures below the 5th percentile for gestational age. It's a feature of many conditions. You see in this patient, other than hypertelorism and microphthalmia, there is also bilateral, prominent focal bulging of the globe. We performed second trimester ultrasound examination for the mother of this baby. There is a cystic mass at the nasal area, just on the medial side of the orbit, between the nose and the orbit. Let's look at the fetal MRI. Now it's more clear that this lesion is in between the right orbit and the nose. This cystic mass is well circumscribed and located in the medial canthus. If you compare right and the left side, there is a dilatation of nasolacrimal duct on the right side. Posterior part of the lesion has no connection with intracranial structures. There is no hypertelorism. This is the picture of baby after birth. There is a spontaneous resolution of this cystic mass after birth. As De Meyer et al. Pointed out several years ago, the face predicts the brain. Certain facial anomalies predictably have associated brain anomalies, such as cyclopia with aprobasis seen in association with holoprosencephaly. Athmocephaly refers to another rare type of midline craniofacial anomaly that's characterized by the presence of extreme hypotelorism, aryania, and a midline paralysis. Sebocephaly is another facial anomaly seen in holoprosencephaly. In this midline craniofacial anomaly, there is a single nostril and it usually ends blindly with proboscis-like nose and hypotelorism. Here in this patient with alveolar holoprosencephaly, there is a central defect in the maxillary alveolus. Failure of fusion of the lip and palate segments during embryogenesis is considered as cleft lip and palate. Bilateral cleft lip palate has a characteristic premaxillary protrusion on profile view, resulting from elevation of the median nasal prominence. In the exterior plane, a midline triangular tissue is seen between the two clefts. Mid-sagittal MR image shows non-depiction of the thin T2 hypointense band of the secondary palate, a finding that's suggestive of cleft palate. The facial clefts can usually be depicted with ultrasound. However, the extent of the clefts and Associated anomalies may be better evaluated with MR imaging. Whenever you need detailed anatomic resolution, you may also acquire 3D volumetric sequences such as space. Both micrognuty and retrognuty involve abnormal, arrested development of the mandible, but micrognuty refers to the size of the mandible, whereas retrognuty refers to its position in relation to the maxilla. A suspicion of micrognuty is raised by the subjective evaluation of the facial profile at the mid-sagittal view, and it's based on the assessment of the geometric relationship between the mandible and the rest of the profile. I would suggest using specific MR measurements for the mandibular assessment. Here in this patient, you see a multilobulated solid and cystic masses originating from the heart plate. Although congenital oral masses are rare, they are readily detectable during fetal ultrasound screening, and follow-up fetal MRI provide the opportunity to make a specific diagnosis by following a simple anatomical approach. The anatomic side of origin of congenital oral mass may be critical in establishing a diagnosis. This giant oral mass is distending the oral cavity and growing bidirectionally. Some part of the lesion is protruding into an amniotic cavity, and the remaining major part is growing and infiltrating the skull base and looking like an intracranial mass. We have already seen some of the head and neck lesion. We have seen lymphatic malformations and congenital hemangioma, and we have to consider both of these lesions in the differential diagnosis of head and neck masses. Here we see left paramidline anterior neck mass in this fetus. MR examination nicely shows solid and cystic parts of this lesion. Cervical teratomas usually manifest as anterior neck masses, causing hyperextension of the neck, and they are typically bulky, multiloculated mass with heterogeneous signal depending on its composition. Let's look at our final question. It's a very big mass. It's located on the lateral aspect of the neck. Because of the size, it's not easy to decide if it is anterolateral or posterolateral in location. These are the grayscale and color Doppler images of the same patient. It has both solid and cystic component. It has some hypervascular area on the Doppler images. Solid part of this lesion is restricting diffusion, but there is no sign of hemorrhage or lipomatous components of this mass. Interestingly, this family has another baby with the diagnosis of embryonal tumor. This case was not an easy case even for the pathologist. Pathologists described this lesion first as the small round cell tumor by just looking at the pathological specimen, but their final diagnosis was grade 4 embryonal tumor. Fetal neck masses are uncommon but very important because they may cause life-threatening airway obstruction at birth. Knowledge of the spectrum of the common and uncommon head and neck malformations and their appearance with fetal MR imaging is very important and essential for family counseling and prognostication and for planning postnatal management.